everyone. Getting very full here very quickly. Our next speaker is Dr. Goolam Mohamed. He is the chairman and the founder of the Sandton Fertility Clinic. He saw this need both within and beyond South African borders with many people who had difficulty conceiving. This state-of-the-art clinic includes the latest technology used to treat both male and female infertility and couples where one partner is HIV positive. Let's give him a round of applause.
Hello, good morning, everybody. My talk is going to be on polycystic ovarian syndrome. Is that a little okay? And it's not a very long talk, but you can ask any of the questions that you may want to after we've finished. So this is, it's not actually a disease. It's actually just a label that is given to a condition that produces some symptoms in the female patients. And how do you do this? You just press it? Which one? Can I just press that? Okay. So there's two terms that I use to describe this disorder, and one is PCO and the other is PCOS. PCOS is actually the more correct term to use because it also combines with PCO, it combines the metabolic disorders that take place, like insulin and hormonal imbalances. So that is actually the correct term to use. And we started learning more about PCOS once, high definition ultrasounds and blood tests became possible. So the causes of PCOS, unfortunately, we at this point in time, we still don't know what exactly causes it, but we do know that there's a genetic component and that females in the same family would tend to inherit the disorder, either from either parent. It's not one gene that causes it, it's a combination of genes that may cause all the disorders that take place. But we know that one of the big problems is that insulin is produced in excess. With glucose metabolism, one has to keep the sugar in very tight control. So if you have to keep that sugar in tight control, the insulin that's required to do that is much more needed. So that's where we get what we say is insulin resistance, where a certain amount of insulin is not enough to actually overcome the glucose level. And it is this insulin that is probably responsible for the weight gain that occurs in this group of patients. So the symptoms that are responsible for all the problems is mainly weight gain, and hyperinsulinemia and irregular periods. This is a problem, irregular periods, and of course, the delayed puberty. So, what is it that actually drives the hirsutism that occurs in these patients? And that is the level of testosterone that happens in PCOS, and it is insulin that drives the production of testosterone, which worsens the condition. If you look at this picture, those are cysts in the ovary, and this is why it used to be called PCOS, because at that particular time, they didn't recognize the hormonal imbalances that occur in this disorder. There were, in 1935 or so, there was two gynecologists, and these gynecologists, their name was Stein Leventhal, the two of them. And they noticed they had patients that had very, very male distribution of the hair growth. They didn't know what caused it, but they did recognize when they operated on these patients that the ovaries were enlarged. And that is the particular problem in they got very large ovaries. So what they reasoned is that the ovaries may be producing something that gives rise to this. They were, of course, very worried about ovarian tumors because that is one of the differential diagnoses that happens. We need to rule that out. So what they actually did is they took away a large part of the ovary. It was known as wedge resection at that particular time. And their reasoning was, if you take away part of the ovary, you'll reduce whatever the ovary was producing, and in that way they'll start, the female will start ovulating. And it did help. And that particular type of treatment lasted right up to about the 1970s, late 60s, 1970s. And it is only in 1970 when hormones were isolated that actually, defined what this disorder was. So this is a little bit of a timeline of the history of polycystic ovaries. It was found in 1935, about, as I mentioned, but it was only in about 1960s that they isolated the hormones that caused this particular problem. And then, of course, in the 1980s, we had ultrasound that actually defined the cystic structure of the ovary. Not only the cystic structure, but it also showed the wider thecal layer of the ovary that produces the male hormone. In fact, the ovary produces, in stimulation by insulin and FSH, both hormones, but it has the capacity in one of the layers, the granulosa layer, to convert the testosterone into estrogen. In the case of PCOS, there's so much of testosterone that's produced that it overwhelms the ovary, and that is responsible for most of the hirsutism symptoms that arise. And the other big problem is, of course, the weight. The weight is stimulated by excess insulin, which increases the production of testosterone, which is the male hormone, and this leads to weight gain. Weight gain, in turn, worsens the condition by increasing insulin. So this is a picture of the control of the hormones. On the right-hand side, that's the brain, the pituitary, that actually secretes FSH and LH, and the LH in turn, FSH and LH in turn stimulate the ovary to produce both estrogen and progesterone and, of course, testosterone. There is a feedback that happens, and the more hormone that's produced, it actually tells the brain to cut off the production of FSH, and in that way, the menstrual cycle is controlled. On the right-hand side, you'll see a little bit of a picture of the menstrual cycle and the different hormones that interplay with each other to actually keep the the menstrual cycle in control. And it's when one of these hormones are out of whack will you get irregular and ovulatory cycles. A woman is generally born, with about a million oocytes, and that never is, there's no eggs that are added to that. So on this graph here, on the graph on the right-hand side, it's just a graph that shows that most of these eggs are lost just after puberty. That's a steep, and this year are lost intrauterine while the baby is still in the uterus. That amount of eggs are lost at that particular time. So that when a person is born, she's born with about probably 1 million eggs, but by the time she gets to puberty, she's only got about 300,000 left, and those are finite. You don't add to that. You don't add to it, and that is why we have this problem that as a woman gets older, her ability to fall pregnant naturally also is diminished. And for example, right at this end here, at this end here, the pregnancy rate is quite high, as we can see, but it drops as the age increases, and by the time they're about 42, it's almost zero. It's all gone. So how does one make the diagnosis of PCOS? Now, in 2003, there was a meeting held in Rotterdam. And at that place, it was decided that there are certain criteria that have to be in place before one can make a diagnosis of PCOS. And one of the criteria, there's irregular menses, there's ultrasound pictures of PCOS, and there's hirsutism. Now, two of those conditions have to be present for the diagnosis to be made. And it's after that meeting that it became a bit clearer that an established diagnosis was made and a treatment plan could be formulated. But in association with PCOS, the condition of hirsutism is the one that makes people very, very uncomfortable. And in PCOS, it's not a done thing that everybody has to have all the symptoms. They should have two of those three to make the diagnosis. But PCOS is a very large spectrum, and on each side you get the extremes of disease. For example, you get very, very harsh hair growth, overweight, a slow metabolism, and on the other end you get very thin PCOS patients who have actually no hair. And then in between, the rest of them do fall. So you get mild PCOS that you can only pick up on blood tests and of course, on ultrasound. And these are some of the blood tests. These are some of the blood tests that we do to actually elucidate the condition. And usually the best time to do these blood tests is during your period, during the female's period. That's why a lot of patients tell us that, look, we didn't come for the appointment because we were having our period. But that is actually the best time to make an appointment with a fertility specialist or with your gynecologist, because it is at that particular time that you can, sort out the whole blood work that is required. And if you see a specialist during your period, that specialist can actually work out a system where by the time you reach the end of the month, you already have the diagnosis of the female partner. The male partner, of course, is very easy and it can be done at any particular time. A sperm test can be done at any particular time after an abstention of about 3 days. So if you're going to see a doctor, the best time to see a doctor is during the periods. It saves time and it saves money as well. There are certain things that are important to remember about PCOS. While it's not a condition that will endanger your life, there are certain conditions that are complications of PCOS. Prominent amongst them is type 2 diabetes. The problem with PCOS is ovulation. Now, those women that do ovulate and still have the metabolic syndrome of PCOS will actually not develop diabetes, and that's an enigma that we haven't been able to work out yet. So, patients with ovulatory PCOS will generally not develop diabetes. Then the other complication is hypertension, dyslipidemia, and the most frightening condition that we worry about is cancer of the uterus that occurs at the age of about 60 years of age. The important thing is that cancer of the uterus can be completely prevented by correct management of PCOS, and I'll come to that a little bit. The dyslipidemia and the weight gain can also be treated so that these tablets don't occur. And that is why it is important that when you're going for treatment of PCOS, that we should actually do a complete workup of most of the hormones so you can keep those that are out of the norm, you can treat them. So once the diagnosis of PCOS is made, one needs to work out a plan. So for the complications of PCOS, for example, for the example, diabetes, hypertension, dyslipidemia, those are conditions that have to be treated separately. But the mainstay of treatment for PCOS is weight loss. It's extremely important to lose weight because losing weight will control all of these complications. It's not going to be easy to lose weight for the PCOS patient because she's not gaining weight because she eats too much. She's gaining weight because of a hormonal problem. And if she just drinks water, she'll still gain weight. And it's important to counsel these patients because they actually get very frustrated. They are after months of treatment, they are unable to lose weight. But what they should be told, and maybe that will motivate them, is that if they lose 5 or 10% of their weight, that's all they will need to restore fertility. And sometimes when you tell them that, they do get motivated. And I've seen patients that lost a lot of weight after some good counseling. So once the diagnosis is made, weight loss is very important. And there is sort of a method. You see, you want to treat PCOS, it'll depend on what the patient's intention is. If the patient intends to conceive, then of course, importantly, she should lose weight, and we can put her on any number of tablets to make sure that she ovulates, and that'll be things like Clomid or Femara. We can also put them on FSH and LH and monitor ovulation, and a lot of them will get pregnant. The only danger is when we use injectables, they tend to hyperstimulate, and that can cause a problem. That is why I feel that if a person has PCO, after 2 or 3 attempts at ovulation induction, if it's not working, the best is to go for IVF because you can collect a lot of eggs from these patients and put back only 2 embryos at a time. And there is such a thing called once and for all, where you do IVF once and you've got enough embryos to actually for a second or a third pregnancy. On the long run, it works out cheaper. In terms of the hirsutism, there's a lot of estrogens, anti-androgens that one can use, like spironolactone. The androgens work in 2 ways. They actually oppose the testosterone in the hair follicle, and some of them prevent the conversion of insulin to testosterone. So there's 2 methods in which this works. But that's the mainstay. But the most important part is weight loss. And the fertility, yeah, that's the options, fertility options, the ovulation induction and IVF. If the person is very young and doesn't want to have children at the moment, there's another option for egg freezing. And that's just about coming now, popular with ladies. Thanks, that's